Well, happy Monday, everyone, and welcome to another episode of You've Got the Power. I'm your host, Dr. Jason Deitch, and of course, we are here with Chief Medical Officer of the Centeno-Schultz Clinic, Dr. Chris Centeno. Good to see you, Dr. Centeno.
Good to see you, Jason.
As always, we've got another great show for you here today. This one also aligns with your daily blog posts. For those of you that have not already subscribed to the Regenx.com blog, Dr. Centeno blogs about important topics every day that are going to help you take back your power and live a healthier life. Today's topic is all about something that is really popular for a lot of people, but may not know, and that is asking the question, can you treat a disc herniation without surgery? Some people refer to it as a slip disc, a bulging disc, a herniated disc. Dr. Centeno, let's break down what is a bulging disc exactly and how should people think about it in today's day and age?
Yeah, so let's kind of put discs into two big categories that are really, let's do three big categories that are commonly seen. We've got a herniated disc, which is where the outer covering of the disc is broken and the inside gel squirts out. And then you've got a bulging disc where that outer covering is not quite broken fully. And so the inner stuff causes it to bulge out. And then you've got a degenerated disc where it just kind of loses disc height and starts to get sloppy in its motion. So those are the three main types. And this particular blog was on a subset of a herniated disc called a subligamentous disc herniation. It acts more like a disc bulge, and it's hard to treat with things like epidural steroid injections. And epidural steroid injections have sort of become the mainstay out there of treating this, and that's injecting high-dose steroids around the nerve. But there are problems with that approach.
Let's get into the details. I know when most people experience low back pain, they oftentimes assume the worst. They want to go, okay, let's rule out a bulging disc. And yet research has also shown us that some people can have disc bulges and have no pain. People can have pain and no disc bulges. How do people navigate, I guess, the severity of a disc bulge, and then how do they know what to do about it? Like you've said, and we talk about on our weekly shows, the most commonly recommended treatments are often those treatments that are not supported by science. How does that relate to what's going on for people and their choices to be able to heal and handle their discs?
Yeah, so epidural steroid injections have been used for some time now, and that's injecting high-dose steroids around the disc. The biggest problem with that is that any high-dose steroid that you inject will have the issue of causing damage to the local cells that are trying to repair the disc. And so, for instance, you end up seeing with epidural steroid injections very commonly that the first one works great, second one not as well or not as long, and the third one almost not at all. Why is that happening? It's happening because each time you're killing some of those local repair cells. So the first time you inject the epidural steroids, they feel great because there's a big tamp down of the inflammation around that disc and the nerve, meaning the disc is irritating the nerve, and that's what's causing many of the symptoms. But you're also killing off cells. So by the second or third time you come in there and you try to do this, there's fewer and fewer cells to help repair and manage the problem. And then the other problem you have is systemic side effects, and that includes things like bone issues in women or increases in osteoporosis, for example. So there's the alternative, which is to use orthobiologics here. And we've published some research on that, and we have been using orthobiologics around the spine really since 2005, 2006. So I and my partner, John Schultz, were the first two people on Earth to inject, for instance, bone marrow stem cells into a disc. And we learned a lot of things since then, what works, what doesn't work. And so the blog was about what we did in this patient using the patient's own growth factors from their blood platelets to avoid all that nasty steroid stuff.
Let's get in and just clarify really quickly, because I know if I'm listening to you and I hear, steroid shots work great the first time, my perception would be, well, then great, let's do them at least once. And I guess what I want to make sure people are hearing accurately, and I don't want to put words in your mouth, I want to hear them from you, is when you say they work, what I believe you mean specifically is that they will help temporarily reduce the pain, aka works, but it comes at tremendous cost and damage in many cases, to which a normal thinking mind would say, yeah, that doesn't actually therefore work. In other words, yes, it may temporarily relieve some pain, but at what cost? And I want to just make sure people don't sort of leave it with, oh, I can do one and that works. Help me clarify so people understand what you mean when you say it works the first time.
Yeah, so all works means is the patient gets some temporary relief, and so they're feeling better temporarily. It doesn't mean usually that the patient's issue is solved. So that first time gives a lot of decrease in inflammation. The nerve becomes less irritated, but it's a little bit like a sugar high. And I've had both. I've had epidurals with high-dose steroids early on before we started doing this work for my own low back bulge. And I've had platelet lysate, which is the patient's own growth factors, my growth factors. And it was a totally different experience. With the epidural, I felt really good, really quick, but it didn't last real long, a couple weeks, and things were right back to square one. If anything, a little worse, because I've been doing all sorts of things I shouldn't have been doing. With the platelet lysate, it built more slowly over time, that first 6 weeks, and then just lasted a lot longer. And again, the difference is in the first one, cells were killed off that can help manage that pain or manage the disc tear. And in the second one, that platelet lysate, instead of a sugar high, it was more organic, if you will, or the body's own resources placed there and amplified to try to help the body do what it needed to do.
Such an important distinction. I know, just for people to understand, this is where you get your power, is understanding what I'll refer to here as the difference between curing versus healing. And curing is about just simply getting rid of the temporary symptom, mission accomplished, but doesn't tend to ask at what cost. You said, the research has shown in time that these steroid injections actually accelerate degeneration. So yes, for a window in time, you can sort of say, oh, pain's less, great, theoretically it, quote, worked. But if you ask me a year, 2 years, 5 years, and more down the line, as you said, the research shows people are actually worse off than had they not taken that injection to begin with. So it's at what cost, and I think that's what I hope most people listening really understand and start learning how to think like doctors. What are you looking for? A short-term benefit with a long-term expense? Or are you willing to be a little bit more patient in terms of the quick relief, because you know what you're actually doing is helping your body heal itself. You're addressing and correcting the actual cause of the problem so that you heal and no longer have the issue, as opposed to faking out your body into thinking it is fine when in fact it's not. It sounds perhaps extreme, but one way to get rid of hand pain is to take off your hand and you won't have hand pain anymore. That's the thinking that goes along with it. Clearly, that's ridiculous. But that is the consciousness. And I want to make sure people understand there is a difference between let's just get rid of the symptom and let's actually heal the body so that these issues don't keep coming back over and over and over again. Any comments on that, or should we start hitting over to questions?
Yeah, we can start taking questions. Just before we do, real quick, look at the blog. We have a nice before and after MRI of a large, subligamentous disc bulge in this guy. We actually had to change things up a little bit, get the stuff closer to between the disc and the nerve, and then ultimately what happened with him is that prior to even coming to us, he had two non-experts in this area take a crack at his back, so to speak. One was injecting exosomes, the other injecting some amniotic fluid. Neither one of them really had much expertise in how to deal with this. Obviously, it didn't work. So he's had nice long-term results going on 2 years now. And so definitely head over to the blog to take a look at that.
Yeah, so essential. And I don't want to just glance over something you mentioned. I know you wrote about it in the blog. I just read it. You mentioned it as well, and maybe even just spend a moment there, which is you were the first to inject the disc. Just like you've also been the first to really create the PICL procedure for upper cervical instability. Just take a moment and really elaborate on yourself. I know you're not one to brag on yourself. I refer to you as the Elon Musk of stem cells because you're really so focused on results, so focused on outcomes, so focused on really helping people better understand what's possible when it comes to, I'll sort of think metaphorically, a sustainable, renewable approach to healing yourself. Help people understand what was your thinking to do something that had never been done back then like you continue to do.
You know, we were frustrated. We had back pain patients with bulging discs that weren't getting any better, or if we could make them better, they'd be right back in the clinic for more. In fact, we kept bumping up. There was this, and there still is, this recommendation not to do more than 3 steroid epidurals in a year. Now, why was that recommendation there? Because even the people that were advocates for steroid epidurals knew that if you kept doing these once a month or once every 2 months and doing 5, 6, 7, 8 a year, that the patient would start to develop severe side effects from the steroids. So we kept bumping up against that 3 number. We had people that would only get well for like a month or 2. And we're like, what do you do with these people? You can't bring them in 6 times a year, 7 times a year, 8 times a year. Because on the malpractice side, all the recommendations are you can't do more than 3 of these things. We also know that's not good for the patient. So how do we treat this patient population? And that's really where this was born.
That is awesome. I love your willingness to just push the boundaries and explore new possibilities, and your track record is outstanding. Let's move on to some questions. This one was submitted in advance by Harry Winston, who asks, if you've already had a disc bulge surgically removed, can you still help? The pain has definitely returned.
Yeah, so Harry, we do treat a lot of patients like that. And usually what happens then is the patient moves into degenerative disc disease. So that means that the level is too sloppy and is moving around too much. And as a result of that, what we do is we go in and we tighten down the ligaments. We also treat the irritated nerves, usually the facet joint as well, and the atrophied muscles there. So that's called a DDD type procedure. So that's a pretty common thing for us to see patients who have had a disc bulge removed, and the symptoms are generally right back.
So whether they've had surgery or have not had surgery, healing and improvement with basically putting your body's orthobiologics in the right area can, wherever you are on that spectrum, oftentimes offer improvement, healing, less pain, etc. Is that usually, do people normally find that by getting first an x-ray and then MRI in order to know sort of the severity of their disc bulge? How would people know how bad it is if surgery was something that was an option, a recommendation? How do most people know, I guess, the health of their discs?
Yeah, an MRI is probably the best thing to do. That will tell us what's going on with your discs. Now, realize an MRI is only one piece of the puzzle. So there are more pieces that we have to assemble: physical exam, your response to treatment, your symptoms, all of that go into trying to figure out how to help.
Right on. If you've had a low back issue, if you know you've had a disc issue specifically and you'd like to ask Dr. Centeno your question, now's your time to do it. We've got a little bit of time left. Let's go to our friend Sabina Saleh, a regular viewer, who asks, hi, Dr. Centeno. I read about how you perform percutaneous scolioplasty. Would you have a similar specific protocol injecting an anteriorly rotated left and posteriorly rotated right pelvis, SI joints, and its ligaments? Thank you.
Yeah, I mean, the nice thing about SI joints is generally it's just tightening down the pelvic ring. There's the right and left SI joint, and then there's a front joint, the symphysis pubis, and many times, especially in women, all three of those joints that make up a ring need to be injected in order to get the best results. So the SI joint is rotating because of the laxity, and if we can go ahead and tighten those joints, it's going to rotate less. Then the other big question would be, is there some sort of side bend or scoliosis in the lumbar or thoracic spine that's putting that turning pressure onto the SI joints? Because when there's a scoliosis in the lumbar spine or thoracic spine, it's going to turn one part of the pelvis forward and the other part backwards. And so if that's present, the scoliosis, then absolutely we can do a combination procedure with that percutaneous scolioplasty and tightening down the SI joints.
It is pretty amazing what's possible these days. If you've got questions, now's the time to ask. Doc, my question for you is, how should people think about their low back pain in general? I know you've got a very strong growing program called your Proactive Membership. The name sort of describes what it is. It's for people that want to be proactive in their health. Talk through your thinking from your experience, both personally, as you suggested, and obviously what you've seen with thousands of people. How should people think about their pain? Is this something that they should sort of wait until they just can't take it any longer, like many medical doctors recommend, because they don't have such great tools? They go, let's not inject or splice and cut until we don't have any other option because you just can't take it any longer? Or are there things they should be thinking, doing? I know you've got your ladder of care. Talk about self-care, conservative care. When people feel pain, should they be just sort of hoping it'll go away? Or are there things sort of at first sign that you would recommend, if it was you, that you would do differently so that you reduce your risk of these more major conditions developing over time?
Yeah, I think for this issue, it's like anything else. It's getting on this early and understanding that it's okay to have a little back pain here or there. But for many people, what happens is the back pain kind of becomes chronic, and then they start having to medicate themselves in order to be active. And that's kind of where I think you should draw the line. If you've got to take a Tylenol or an Aleve or a Motrin just to be able to go and take a walk or work in the yard, that's when you got to get it looked at. And we've got to start figuring out what's going on. So having some episodic back pain that goes away on its own is one thing, but getting to the point where you're having to medicate yourself to function, or for instance, if you know that every time I go and do anything in the yard, for example, spring's out there, people are starting to get in the dirt, then that's the time to get it taken, really take a look at it and see what's going on.
I love your saying, small problems require small solutions. If you wait, you let these problems progress, they become bigger problems that require bigger solutions. Bigger meaning more expensive, more invasive, and takes longer time. So the sooner you get ahead of these things and stop hoping they will go away, yes, you can heal yourself, but when you feel something is chronic and it's sort of happening in a pattern, that's the time to at least get it checked out. These conditions, as Dr. Centeno did say, if you did something, if you exercised excessively or you did something that would logically cause a reaction or response that way, that's one thing. But when it's happening through your normal day-to-day or regular activities, that becomes something else. Let's go back to some questions before we wrap up for today. Louis Cranston asked in advance, we've been talking about disc bulges in your low back. The blog is about L5-S1. Does this principle apply to the cervical spine, to the neck region as well?
It does. So we've treated lots and lots of disc bulges in the cervical spine as well. And principles are pretty much the same or very similar. So yes, we've treated lots of patients with low back disc or cervical disc bulges, in addition to thoracic disc bulges as well. So we treat all three areas, the neck, the upper back, and the lower back.
Outstanding. Petra Miku asks, hi, Dr. Centeno. Some of us have been recommended a disc replacement or an ACDF for more serious stenosis. She goes on to ask, what is your opinion about ADRs?
Yeah, not a huge fan. I think the original idea with ADRs was that they were supposed to reduce the amount of motion, increase the amount of motion over a fusion, right? A fusion just locks it down. An ADR or an artificial disc was supposed to allow some movement. But the research really didn't pan out on that. If you look at the non-advocate research, meaning research done by people who aren't on the payroll for companies that make ADRs, what you tend to see is that an ADR behaves a lot like a fusion. So you really don't get that benefit of the extra motion. And no one's 100% sure why that is. Maybe it's because it's getting scarred down due to the surgery. Maybe it's because the motion is so dramatically different than as the body was built. But you're still seeing the same amount of adjacent segment disease above and below ADRs. So because of that, I think you've got to be really careful with the concept of an ADR. Plus, if you think about it, you're making a hole big enough to put a small hockey puck in your neck or your back and in your spine. And that obviously has other implications. So if a hockey puck is not centered right, in fact, I'm dealing with one patient right now, that's the issue in the neck, or if the hockey puck comes out, goes back or forward, all of those are big, big problems. So not a huge ADR fan for those reasons.
Yeah, and what this is, as we close up for the show, I guess let me just sort of ask you to maybe elaborate on that a little bit longer. I think, my experience as a chiropractor, your experience, as an orthopedic expert, I don't think most people in the public really appreciate the sensitivity and the I guess, complications of the spine itself. The articulations, the nerves, the joints, all the different facets, the different areas. And what most people don't really, I'll say, connect the dots on is that the spine includes inside of it the spinal cord and then the nerves that go out to all the other areas of the body. Most people think of the spine as just a bunch of bones stacked on top of each other, but yet it is there to protect the most valuable part of your health and well-being, literally the spinal cord, metaphorically being the tail of the brain. It's the electrical system of the body. When I hear people ask questions about, drugs versus healing, artificial replacements versus less invasive ways to help the body heal itself, that tells me that there's a major gap in people's understanding and appreciation of just how complex the spine is, how careful you want to be when doing anything to the spine at this kind of level. You talk about irreversible surgeries and drugs that just make things worse. Help people understand just how important their spine is because of its relationship to the spinal cord, the spinal nerves, etc. So people can hopefully realize how sensitive, important, and valuable it is to make sure that they're taken care of and not just waiting until they just can't deal with it anymore, expecting to drive themselves into your office and, leave their bodies and say, when should I pick it up? Tell me when it's going to be better. And yet it's a thing they have to live with every single day. Your thoughts on that?
Yeah, I mean, the reality of all of this is that your spinal cord is your reality. And what I mean by that is that if I pinch a nerve that comes out of your spinal cord, you wouldn't really feel it in your back or your neck. You would feel it in your arm or your hand. And we see so many people who have problems in their hips, their knees, their ankles, their shoulders, their elbows, their hands, where there's really just nerve irritation in their neck or their back. And if you treat that nerve irritation, the knee problem, the hip problem, et cetera, go away. So you have to realize that anything that's messing with those nerves or spinal cord is an important thing to pay attention to and look at.
And the key word, I think, would be sooner rather than later. Let's take a few questions. We'll wrap up. Megan May. Hi, Megan. She asks, are there discs from CO to C3? Great question.
Yes, there are. Well, there's a disc at C2-3. There is no disc at C1, C2, and no disc at C0, C1. So the top two vertebra and articulations, C0, C1, the head and the atlas, C1, C2, the atlas and the axis, have no disc. It's all facet joint there. Then you get into C2-3, which does have a disc, and on down. So that's what makes those that upper area quite unique, is that the high upper area, skull base 1 and 2, don't have discs between them.
A lot of motion, a lot of movement. I want to make sure it stays healthy, but certainly not from the disc standpoint. All right, well, let's wrap it up with Kimberly, our friend from watching down in La Paz. She says, cheers from La Paz, gentlemen. Cheers, Kimberly. We're a little envious, I think, but hopefully you're enjoying it. She says she's 6 months out from PRP and stem cells into L4, L5, L5S1, and still feeling great. Very much what your blog post is all about. I know you've got thousands of people you've helped over the years with these types of conditions. Why don't we wrap up today's program with some hope that if people do have some sort of low back pain, especially, I'll say back and neck, especially if you have been diagnosed and you've got imaging with an MRI that in some way has said you've got a bulging disc, a slip disc, a herniated disc, whatever adjective they put in front of the word disc, that help might just be available and help them understand what they should take, what they should do as a next step in order to take better care of themselves.
Yeah, so I think the first step is make sure you have an MRI, and then second step would be no matter where you are in the world, you can get on a telemedicine hookup with any one of our Regenix doctors or Centeno-Schultz clinic, and so that's an easy thing to do. And then, the third step would be looking at how we get that area better and what the game plan is to do that. And that game plan is individualized for the patient. There is no one size fits all here where we can just go ahead and do everything the same in the same patient. So just realize that that's individualized based on what's going on with you.
Fantastic. That's our show for today. We really appreciate it. Kimberly follows up. She says it was totally worth flying from southern Baja to Dallas, I assume, and then to probably Colorado or wherever she ended up getting that. That's the way it works. Help is available. You just got to reach out for it. And if you'd like to know if you've got coverage for your next upcoming Regenix procedure, you can go to the website regenixcoverage.com. There are up to 8 million of you out there that have coverage for your upcoming Regenix procedure. Many smart employers are now covering this as a covered benefit, and you can go to regenix.com to find out if that's the case. Bottom line is stay connected with us. Make sure you're subscribing to see our shows when we go live. We're here Mondays on the Centeno-Schultz page, on Fridays at the Regenix page. Hopefully you're getting the blog. You can go to regenix.com and subscribe to that, and you are staying part of this conversation. And when you learn something that you think is valuable and important, our ask is that you share that with other people. We're here to share with you things you probably won't find at every doctor's office. You won't find in every Google search. This is a different perspective than what you're going to find at your traditional medical doctor that provides drugs and surgery. This is an approach to helping you understand that you can heal yourself and then guide you to the ways in which you are then able to do so. That's what it's all about. So if you find something interesting, please share it with other people. That's how we help and serve more. That's how we help invite more people to get better health faster, easier, and oftentimes less expensive than the other traditional, dangerous, risky perspectives. Doc, any closing comments before we close for today?
I think, listen, there are non-surgical ways to help heal disc issues. We do it all day, every day. So just keep that in mind. Or if you know a friend who's been told, hey, you need back or neck surgery, good to intervene and say, you may want to get a second opinion on that, and let's try to look at something else.
That's what friends are for. That's what it's all about. On behalf of Dr. Chris Centeno, I'm Dr. Jason Deitch. We thank you so much for joining us. Kimberly, keep enjoying the whales. Maybe post some pictures or videos next time so we can all appreciate what's going on down there. Until Friday, enjoy yourselves. Have a great week. If you've got questions or would like to schedule a telehealth appointment or at a Regenexx office near you, reach out. You can go to the regenexx.com website for the local provider, or you can go to the Centeno-Schultz clinic site right here connected to this page right here, right now. Either way, get help. Help your body heal itself. We're here to help you do that. Thanks for watching. Until Friday, stay well and be kind. Be well, everyone.